you already know, we started a biomechanics course this year with Dr. Amparo Gomez and I. And we have a very special session. This is the closing session. And our guest is Dr. Brett Crist. Dr. Brett Crist is the Director of Orthopedic Trauma Service and the Director of Orthopedic Trauma Fellowship in the University of Missouri, Columbia. And he's also the author and editor of the book Essential Biomechanics for Orthopedic Trauma that was published earlier this year. So Dr. Crist, welcome, and thank you for accepting our invitation.
Oh, it's my pleasure. I'm not able to, it says I can't share my screen because the host, oh, now you did it. Awesome, thank you. It's working now. Let me, I shared too much. I shared my whole desktop. Hold on just a second. Can you see the PowerPoint okay?
Yes, we can see it.
Okay. And if you, how would you like to do questions? Do you want them to put them in the chat, or do you want to have time at the end to do it? Whichever is easiest for you guys is fine with me. I can try to answer them at the end if they're submitted through chat, or if we want to do them live, that's totally fine as well.
I think it is better at the end of the lecture.
Okay,
thank you.
All right, so thank you so much for having me. It's an honor and a privilege to speak to you remotely. It'd be nice if we were all together. For sure, it'd be more enjoyable. This is a great way to continue to educate about orthopedics, and hopefully everybody gets a chance to interact if they would like. So why is this important to orthopedic trauma surgeons? Well, this is I'm going to cover a lot of different kind of cases to try to hopefully prove the points that I'm making. So this is an active military 25-year-old male. There's a base about an hour and a half from us where they have a large training facility. So it's not uncommon for people to get stress fractures. So this person completed a stress fracture and treated at the local hospital, and he underwent closed reduction.
Dr. Crist, I'm sorry, we are hearing very bad.
Okay.
Yeah, it's okay now.
It's okay now? Okay.
Yes.
If it, just tell me again if something bad happens. But this was a 25-year-old who underwent percutaneous pinning of this femoral neck fracture 3 months ago. He was having pain, and he presents with these x-rays. And this is his lateral view. And so we're going to talk about how biomechanics affect fracture healing, how fracture surgery incorporates biomechanics. Have you utilized operative techniques that incorporate biomechanical principles to improve fracture healing? And then review how deformity, not just fractures, but deformity alters biomechanics and how surgery can improve them. And so why didn't this fracture heal in a young 25-year-old who, this guy didn't break his femoral neck like jumping out of an airplane or anything. This was a low energy, like just had it break on him when he was running. And so why is it important? Well, this is particularly important for primarily young femoral neck fractures, but also geriatric ones as well. But there's always potentially another option for an 80-year-old. You know, you can always do an arthroplasty, but for a 25-year-old, you don't want to jump to arthroplasty. And so why is this important to understand for femoral neck fractures? Well, in young, quote unquote, young femoral neck fractures, so anybody that's really 55 or younger or 50 or younger, depending on the study that you look at, their non-union rate's around 20%. And you can see by this diagram the resultant joint reactive force experienced by the femoral neck and the hip joint. And you can see this is where biomechanics and different geometry can help you kind of with your surgery, basically. So in fractures that are perpendicular to this resultant force, they receive compression. So if it's a low angle femoral neck fracture, the reactive force ends up helping fracture healing. But if they're more vertical, like a Powell's 3 type fracture, which I'll show here in a second, creates more shear force, which makes it harder for the fracture to heal. And so it really inhibits fracture healing. And so you have to figure out how you can alter the biomechanics, either with reduction, fixation, or considering a stress altering surgery in addition to fixing the fracture. And so this is Powell's classification that was done a long, long time ago. And this is just really looking at the angle created with the horizontal and the femoral neck fracture. So as you go from a Powell's 1 through 3, the femoral neck fracture becomes more vertical. And he showed that as you go from 1 to 3, the shear force increases, and it led to higher hardware failure rate and non-union rate. And really it's Powell's 1 is less than 30, Powell's 2 is between 30 and 50, and Powell's 3 is actually greater than 50. And so biomechanics do matter. And some things like this, like when I was a resident, we had a book that we went through, and it was pretty good. It helped us kind of go through the diagrams that I'll show, some of them that I'll show. But I really thought it would be helpful to have a book that really showed case examples to kind of get, at least from a fracture standpoint, the biomechanics across. And so that's why we did that book. So why didn't this fracture heal? So this is a 42-year-old obese female. She's about 300 pounds with 4 previous attempts at trying to get this simple transverse fracture to heal. Like, there's a lot of cables in there. There's plates and screws. There's a retrograde nail. There's broken screws. You know, why didn't this heal? And why did this make it heal? So after treating her in a staged fashion with an antibiotic nail to deliver local antibiotics and stability, I then decided to do dual compression plating because revision nailing and plating didn't help either. So I tried the nail plate construct. It didn't work in this patient. And so basically went back and flattened the fracture surfaces to get back to healthy bone, and then used the percutaneous articulated tensioning device on the lateral side with a long lateral distal femur plate to compress on that side. And then at the same time, used a small fragment articulated tensioning device on the medial side to compress that. And then, or large fragment, sorry. And then was able to get it healed. So at 10 months, after kind of several years of trying to get this thing to heal by people, she ended up healing it. So why did that work? So fracture reduction affects biomechanics for sure. And so this is a simple diagram from a talk that I gave for the AO basic course. But an anatomical reduction with absolute stability and direct reduction techniques take the 2 bony surfaces, visualizes it, directly manipulates it, and gets them to an anatomical reduction. And by getting them together when it's a simple fracture pattern, it helps add biomechanical stability to the overall construct. And then if you provide interfragmentary compression, that adds more stability. So the reduction adds to construct stiffness because you're not putting as much stress on your implants and getting bony contact. So if we have an in-training exam in the United States that all the residents take. And so there's always some question about, you know, the biomechanical stability of external fixator. Like, how can you affect the biomechanics of an external fixator? And everybody gets caught up with, you know, the pin size diameter or the thread size of the rod or how far it is away from the bone. But the number one thing is fracture reduction. So fracture fixation affects stability. So in the 2 books that you guys are looking at, references that you're using, this is from the book that I edited. So hopefully you've seen this one, but this is looking at the force displacement curve and looking at how basically that stress strain curve. So the amount of stress it sees and over the amount of displacement or the strain, plus the structural strength of whatever you're using for fixing it. And so for rods, you know that it's pi r to the 4. So just increasing the radius by 2 millimeters obviously changes a lot. That's to the 4th power. So that's a significant increase in resistance to axial bending. And then area moment of inertia basically is the shape of the construct, more like a plating construct. And so this is how fracture fixation either makes it or it doesn't, because I explain to my patients all the time, like, no matter what we use for fracture fixation, we need your body to help heal it to avoid fatiguing the implants. And so this is the stress strain curve of showing the elastic zone, which is basically kind of between where the line 1 or the first yield, the first segment is the shape after the load is removed. And then, but you have that elastic range where you get up to the yield point, and then it's permanently deformed basically. And then you go to the ultimate load that it can withstand. And then you go to your failure point as you keep moving further to the right with the stress strain curve. And so these are just diagrams showing what the original shape of whatever your stress or your stress is, that the thing that you're applying stress to, and what happens when you get to that 4th place where you've basically caused failure because you've put too much stress on it and it can't take it anymore. And so then we start thinking about specific implants. And so we use plates and screws all the time. We use screws independently. And so what is a screw? It's definitely a way for us to either maintain the reduction that we get through whatever means you're using, whether it's direct reduction or indirect reduction techniques. And if you don't get an articular surface anatomically reduced, you're potentially creating a fixed malreduction. But here you can see with this fairly straightforward medial plateau fracture that the screws are providing the compression across the articular component of the fracture. And so it's generating compression, and that's how it works. And so what don't screws do a good job at? Resisting shear. And so we want to use some type of augment to try to resist the shear forces that particularly this tibial plateau fracture is going to see. And so there's lots of different screw functions. Like I was just saying, compression, like that's what a lag screw does. It can be a position screw if it's maintaining the position of the bone that's reduced, or it can help hold a plate down or generate compression through the plate using the plate though. And so the plate type and function also is. Oh, sorry.
Por favor, apaguen los micrófonos.
Yeah. And so what function is this plate doing? So this is basically a buttress plate. And so that first screw is helping that plate function as a buttress because it's trapping the fracture. It's preventing the fracture from displacing in the axial plane. And so it's supporting those lag screws which is lag screw by technique, because it's preventing the shear forces that would make the fracture move or displace in the axial plane. And then so if you've done the basic principles course or some type of variant of that, you know that plates function in lots of different ways. It can be a buttress like this, or if you flip it around for the fibula, it would be an anti-glide plate. If you place it on a forearm, it can be a compression plate. If you place it around the elbow, it can be a tension band plate, or whenever kind of any plate is on the tension side. We'll talk about bridge plating as well. There's lots of different functions, and you can use it with the same exact plate. And so that's why it's important to understand the different functions of the plate and how that affects your fracture construct stability, as well as how the fracture heals. And so this is a very common theory that has been perpetuated from Professor Perrin, who just passed away over the last year, where it's basically looking at what leads to fracture healing. And so if you have a small gap that's fixed, there's too much strain across that surface for the osteoblasts and osteoclasts and osteocytes to lead to fracture healing. But if you have a large gap with multiple fragments, it distributes that strain to where it will go on to heal. And that's where the idea about bridge plating or IM nailing works with multiple fracture fragments. And so basically the group of fracture fragments shares the load rather than having that fracture surface at a small fixed gap, seeing all that strain. And really, so it's important to understand that in a simple fracture pattern, if you're not generating compression and really getting that contact to where your plate is adding to your stability, but your fracture reduction is adding to your biomechanical stability and stiffness, then you're really going to create too much strain to get it to heal. It's just too much strain for the bone to form. And so then if you go to relative stability, there's kind of a misconception that the implant is the key element in stability. So this is a straightforward femoral shaft fracture treated with a retrograde nail. And this is kind of always thought of a medullary nail as a load sharing device, because basically you're along the central axis of the femur. You don't see a lot of moment of inertia causing stress along the outer part of the bone like a plate sees. And so in comminuted fractures, the idea is that a plate is a load bearing device because the fracture isn't helping at all, or a plate is considered a load bearing device. And I would say that's not necessarily always the case, because in this comminuted femoral shaft fracture, this nail's a load bearing device. It's not a load sharing device, because there's really no diaphyseal contact that's helping with stability in that fracture zone. It's a short working length, and there's really no shared contact between the fragments to add to stability. So this is a load bearing device in this situation. And then this is a patient who had an external fixator on because of a knee dislocation. And so that's part of the reason why I plated the femoral diaphysis fracture, because I didn't want to affect the ability to do the ligament reconstruction where they needed bone tunnels and things like that. And so basically, is this a load bearing device? The fracture was compressed through the plate and it has good cortical contact. I would say this is more of a load sharing situation. And this is what it looked like at the time of healing. And so fracture factors affecting stability and biomechanics include the fracture pattern and bony contact, the type of implant and how it is applied, the bone quality, and the applied load. So if you have a medullary nail in a geriatric patient with really poor bone quality and no cortical contact because of comminution, that's probably not going to do as well with a plate applied laterally than a nail, because the nail is going to be more in the central location. So the moment of inertia on the outside or the stress on the implant isn't going to be as great as if you plated it on the lateral surface on the tension side and then had that varus moment on that fracture all the time, the implants bearing the load. And so I describe it to, or explain it to my patients this way: basically, like whatever we use is like a paper clip. So the more you bend it, or the number of cycles that it happens or sees that stress, the more likely that it's going to fracture or fail if the bone doesn't start to help. And then also the applied load can be a big component. So if you have, and I'm sorry I'm speaking in pounds, but if you had or I'll go with kilos. So if you have a 120 kilo patient versus a 55 kilo patient, they're applying more load across your implant for the same fracture, that higher weight patient. So the 200 kilo patient is going to be applying a lot more load than the 100 kilo patient. And so that should kind of help you determine what your post-operative course is going to be. And so there's sometimes, like in geriatric patients, where we run the risk of hardware failure because we want to get them up and moving faster. And so how can implants affect stability? Well, you want to stick with basic principles. So I talked about a buttress plate. So this is a distal femur fracture with the exit point is high and medial. So if you wanted to buttress, or technically it may be considered an anti-glide position, because you're trying to prevent shear force in the distal to proximal stress. You know, is the best place to put the implant on the lateral side or the medial side? And kind of the, you know, most people's gut reaction is, well, I want to put it on the lateral side because we have laterally based implants. But if you look at this particular fracture pattern, you're really not going to get that much fixation into the distal segment, and your plate is not functioning like a buttress or anti-glide plate. And so that's why I think it's important to feel comfortable doing medial distal femur plating. And so that first screw in the proximal aspect of the plate is actually just with the screw pattern in that plate is more of the first screw that was placed was the second screw, and then the screw that's the most distal in the metaphyseal region is actually a lag screw. So where do you want to put your thumb in this one? And this is, so it's a left femur. You can see lateral displacement and translation. This is more involving the articular surface. So there's an intercondylar split. There's medial cortical comminution. So, you know, one thing to think about is that there's medial comminution. So there's no opposite column stability. There's not a ton of comminution, but still you're not going to get a lot of help from the medial column contact. So in this one, I still, the initial fracture displacement was the distal segment wanted to translate laterally and proximally. And so I wanted to push there. And so that's why I put the lateral plate in addition to fixing the articular surface. And they had a simple tibial plateau fracture as well that just treated with screws. So what about this one? This is a 17-year-old who just was playing soccer and had pain and then couldn't walk after that. So he presents with this kind of distal third femur fracture, extra-articular. He still has partially open physes. And there was concern that, well, maybe he has some type of bone tumor. So is this pathological? And it wasn't. So there wasn't any concern for pathological fracture. And so where do you want to put the implant for this fracture? So kind of like that other fracture, it's a high medial escape. And so I want to put my thumb where I want to reduce it. And some people say, well, what if I just push my thumb on the lateral side? Won't that help as well? And I would say that's not going to reduce the axial translation that you have. And so really the position of the thumb is going to be medially to push lateral and then distally so you get the reduction. Pushing on the lateral side would just create a valgus motion and you wouldn't actually get a reduction. And so my plan was to place, so this is not a small percutaneous medial approach. This is a subvastus approach with small proximal incision to anchor the plate proximally, but I wanted to put it medially to buttress. And so this is the first screw that goes, I always put like provisional wires to set up everything, but this is the first screw that goes in to try to affect reduction. And then, so just like in the forearm, I'm trying to create an acute angle to compress against. So that second screw on the image on your right is a compression screw, but I'm still not happy with that gap. And so is that going to create a fixed small gap that's going to lead to non-union? Even though he's young and healthy, it could, because it's potentially going to see some stress. This wasn't a comminuted fracture. It was a simple fracture pattern, and I wanted to make sure the fracture was compressed. So the next thing I did was a lag screw by technique. And so this is the immediate post-op imaging. You could say, well, why not do a nail? He still was growing based on questioning him. So I didn't want to violate his distal femur physis if I could help it. And so here he's at 2 months, weight bearing with no assistive device, no pain, full knee range of motion. And I could never get him to come back again. And so you're like, well, wait a minute, you did compression plating and a lag screw, but you can see that he has periosteal reaction and callus formation you can see on the lateral view anteriorly and posteriorly as well. And so why did that happen? And so that would say that I didn't get absolute stability as much as I thought I did, but he was also walking on it right away. So he barely used crutches after he left the hospital. And so part of that is that applied load that he's seeing. So these were non-locking screws, although it's a locking implant. I wanted a longer plate, and so this was a longer plate option that I had. And so these are all non-locking screws, but it tolerated him being able to ambulate on it pretty much right away. And so the plate helped provide enough stability along with the fracture configuration to allow him to really get going early. And so how about when it doesn't work? Like, why do people get non-unions, or why don't fractures always heal? And so this is a 65-year-old who presented to my clinic 4.5 months after this was done to her. So she had an open fracture medially. So her wound is the fracture wound that she had, which is where the arrow is pointing on the medial tibial surface and kind of posterior. So it wasn't directly over the cortex, it was just slightly posterior to it. And then she presents with increasing pain. Her leg became deformed, but you can see that 4.5 millimeter implant was used. You can see all the broken screws, the 3 above the fracture, or partially above the fracture. You can see the fibula plate. The fibula was comminuted. You can see that the implant's bent. I don't think it was reduced that way because the middle, or the kind of the section where there's screws that weren't used, look like it's bent into varus, but it may have been reduced in extension. So I would say that the person who did this surgery doesn't really understand biomechanics for a variety of reasons, because number one of the things that we tell our residents are screw holes are opportunities, not obligations. And so basically every screw hole had a screw in it. And that's going to lead to a very rigid construct that can create a fixed gap. Like Dr. Perrin had mentioned, if you have a fixed gap with a really stiff construct, you won't get it to heal because the strain is too high. The other thing as it relates to this particular fracture is that there's screws in the fracture site. And then on the fibula, it's great how long the plate is distally, but they really short-sighted the proximal segment. So again, it's short segment, or the working length is very short in the proximal segment, and the amount of stress on the implant is very high. Even though it's comminuted, it's not really bridged well, so the working length is too short, and so it leads to a lot of stress on the implant. So the next thing would be that plate would break as it continues to go into varus. So what would understanding biomechanics change? Well, this is a paper that was published a long time ago, so 17 years ago, but it really kind of made me think about how bridge plating works. And this was done, I'll kind of go into the details about the screws and stuff, but this really looked at like bridging length, number of screws, and how it affected the biomechanics. And Dr. Stoffel is the first author. So they used titanium 4.5 millimeter LCP plates, and that's why you see the holes are the combi holes. And these were done with unicortical screws. And they did biomechanical testing and then finite element analysis. And you can see the outputs for axial stiffness and torsional rigidity, torsional rigidity based on the numbers at the bottom of the graph are basically correlate with kind of the screw position and number of screws. So that's why it has those numbers by it. So that's basically the plate number, the hole in the plate that's filled with a screw. And they looked at working length and one hole more basically. So if they added one more, like adding one more screw, or sorry, one more hole away decreased axial stiffness by 60% and decreased torsional stiffness by 30%. So instead of being right next to the fracture, they moved it, the near screw, they moved it to the number 2 hole, that decreased stiffness in the axial plane as well as torsional stiffness. So it created a more flexible construct. Up to 3 screws on each side added axial stiffness, and the 3rd screw, especially if the 3rd screw was close to the fracture. So like the 6-2-1 would be better than the 6-5-4-3, if that makes sense, or the 6-1. So the torsional rigidity, if you added up to 4 screws, that would add torsional rigidity, and it didn't really matter what position the 4th screw is in. If you increase the distance of the plate from the bone itself from 2 to 6 millimeters, it decreased the axial and torsional stiffness. So the further than 2 millimeters away wasn't really a good idea. And then the highest stress was seen at the screws near the fracture. So small gaps increase plate length to make the plate more flexible. So if you're trying to do bridge plating and simple fracture patterns, you want to make a very flexible construct. Otherwise, you're going to, not understand what Dr. Perrin was saying, because you're creating a fixed gap if you make it rigid. You need the bone ends to touch to be able to get the fracture to heal. And then with large gaps, you want to increase the number of screws just to help with fatigue, basically, and increase some stiffness. So for this particular patient, I had several goals. So I thought she was older. She had an open fracture. She had a biological challenge. And she also needed more stability. I also was concerned about infection, but her laboratory workup showed no obvious infection, but I like to, don't always believe the infection workup. So I talked with her about doing stage management. So took out her implants, debrided her fracture through her open fracture wound, and then put an antibiotic cement spacer there, and took 6 weeks of prophylactic antibiotics. And then the plan was to come back and provide biological stimulus. So I used the Reamer irrigator aspirator device to harvest bone from her femur, and then took new cultures, again, put a medially based plate, because if you remember what her fracture failed into, it failed in varus. So you want something to resist that varus moment. And so medial implants would help with that. I was also worried because of her bone healing potential, just with her age, and she had some medical issues like diabetes. I wanted to create some opposite column stability instead of putting all the stress on that medially based implant. So I added a fibular strut because I didn't want to put a super rigid metal implant laterally. So I placed a fibular strut and connected it to her with 2 screws, and then also fixed her fibula, as you see here, and bone grafted it. This is what it looked like intraoperatively, and then did pie crusting techniques to allow for easier closure of her wounds. And so the way they did their initial incision, I could actually address the fibula through the, put the fibular strut on the tibia through that same incision. And so this is what she looked like post-operatively. This is what she looked like at 4 weeks. So she looked pretty good. Her incision was healing well. Her x-ray showed no obvious failure. This is what she looked like at 4 months. She had no pain with weight bearing. She started weight bearing as tolerated at 6 weeks. Radiographic healing, or I thought there was callus formation on 3 out of 4 cortices at that 4-month standpoint or time point. That's the lateral view. And about at 6 months, she had some issues with some wound healing issues. And so we actually debrided her and put some antibiotic beads in. But you can see here at 9 months, she healed both fractures, her tibia and her fibula. And so how about this one? What went wrong with this one? This is another open tibia fracture. So this was treated with debridement and then initial external fixator application. And then they rotted it with 2 locking bolts distally, 1 locking bolt proximally. Had a comminuted fibular shaft fracture. And so again, I think, so this is showing that, you know, nails don't always work. No matter, we think a reamed medullary tibial nail will work great. There are some issues with this construct. So problems were that he has an open fracture. He had 1 locking bolt proximally. I don't think the zone of diaphyseal contact is that great proximally. So I think he had some instability there. He had a short working length distally. So the working length is between the fracture and the first point of fixation. So that would be between the fracture and the medial to lateral proximal, or sorry, the medial to lateral locking bolt distally. So that's a pretty short working length. And he also had a comminuted fracture of the tibia and fibula. And he also had initially into varus, no cortical contact, and fibula comminuted. So this is, he came back at 4 months with a draining wound and increasing varus displacement. So we went back, debrided him, and put, I thought he would not do well with just a standard Elizaroff-based antibiotic nail. So I actually made a locking nail with different Elizaroff parts. And then came back after he had some antibiotic treatment and put a larger, longer lock nail with reaming and actually harvested bone from his tibial canal on this side and packed it, and he actually got another flap. But this one, the working length is longer. He's got more fixation, both proximally and distally, and a bigger nail. So like that biomechanics diagram, pi r to the 4th for axial stiffness, you know, I increased his nail size from a 10 to a 13. So 3 to the 6th is a lot. And so at 6 months, he has 2 out of 4 cortices bridge. He's not having any pain and no failure. So kind of last thing we'll go over is deformity correction. And so this is, some of you know Dr. Kafuri, he's my partner. We love doing deformity correction. And so why does deformity cause a problem for joints, or if it's with healing, like we talked about with the femoral neck fracture, but why does it cause biomechanical problems? So you can see this girl is 19 and she has Blount's disease, and she is 200, so she's about 130 kilos. You can see she's a big person. And you can see that her left knee is not having a good day. It's seen a lot of bad days because her legs are at different lengths and she has a significant varus and even subluxating knee. And so these are her angles using planning software that we have. There's a lot of red numbers on here, meaning that she has issues with her femur and her tibia, as you can see here. And you can see that her ankle's not having a great day either. And so she had so much correction problems that, and she was big. So how can deformity correction surgery affect the biomechanics? Well, we can change the bone. And if it can, if you don't address the mechanical problem. So this lady had such amount of deformity, I didn't think I could acutely correct her. So she actually had 3 high tibial osteotomies. The first one was with Taylor spatial frame, so a circular frame, and I maxed out the correction that her soft tissues would allow. And then we went back and did another, basically about 15 degrees was the maximum I could get this one to do, but you can still see that it's not right. Like it's better, but it's not right. And so if we left her like this, she'd still have a varus overload and have a leg length discrepancy. And so this is looking at just kind of changing the proximal tibia again, but you can still see that her lateral distal femoral angle is off. And so we actually, Dr. Kafuri and I did this one together. We did a proximal tibial osteotomy again to get her joint line level and distal femur closing wedge osteotomy, as you can see here. And so her leg lengths were much more similar. And she basically got her mechanical access, McCulloch's line, right where basically it should be. And her medial lateral distal femur angle still is not normal, but her joint line is really good. Like it's 0.1 degree off, and her medial proximal tibial angle is normal. Her ankle joint's normal. So it was a big win in a very large person. So in summary, we started out with fracture reduction, how that affects biomechanics. So if you get a simple fracture, get it reduced, it'll take a lot of stress off your implants, which fracture fixation does matter. Utilize principles to get fractures to heal because it can go back to principles. And so this was how they initially fixed the fracture. And I didn't show his initial films, but the reduction really didn't change. The screws weren't in a great position. The posterior inferior screw is actually went in the bone, out the neck and the back, and went back into the head. So he's lucky that he didn't get avascular necrosis. But this really wasn't a triangle. The screws were very clustered together. And so it was not only not a great reduction, but not a great fixation. And so, you know, maybe this type of implant, which is the femoral neck system, is potentially something that will help with high angle femoral neck fractures. I actually always add a compression screw above it. And we'll see how this implant changes versus I usually use a blade plate before this was available. And so this is what ends up with that patient that I showed with the femoral neck non-union. We went back and did a femoral neck osteotomy, and I actually couldn't get him to, this is his post-op, and I couldn't find his 6-week image, but he actually had his femoral neck fracture non-union. He was ambulating with one crutch, and then he moved to a different state. But altering the biomechanics gets the fracture to heal. For this fracture, it was a Powell's 3. And so by just changing the forces that it sees, you can get the femoral neck non-union to heal. So with that, we've got, definitely have some time for questions. And so we'll open it up for questions.
Okay, Dr. Crist, thank you very much. Excellent lecture. It's a fact that a better understanding of the biomechanical principles help us to avoid many of the complications in surgery. And I think we should always use biomechanics to get a better results in our surgeries. But I think it's also a fact that many of the residents and some attendees, especially when we are starting in the world of trauma, consider that biomechanics is not very easy to understand and it's quite complicated. And there are a lot of residents in the session right now. So could you give them some tips or some advices to a better understanding of the biomechanical principles?
Sure, I'll give it a try for sure. I think the things that helped me kind of think about it more is really how, so that stress strain curve is something that you think about for fracture fixation, or at least I think about all the time. So I think like, how can I affect that stress strain curve that I had towards the beginning of the talk? Like what are the things that are going to affect it? So the things that, you know, we had to memorize for our yearly exam was, you know, the things about the stress strain curve as far as the elastic part versus the yield point and then the failure point. And that really is when you see a fracture and how you're going to fix it, if you kind of think about it, like, how can I affect that? So does fracture reduction affect it? Absolutely. So if it's a simple fracture, if you want to avoid directly reducing it and trying to do it percutaneously or use closed reduction techniques and do minimally invasive plating, then you need to think about what that does to your stress strain curve. So if it's a simple fracture, then you need to make it more flexible. If you have simple fracture. I tried to do that a lot early on in my career, where I'd push the minimally invasive plating. It was very popular. I tried to push the envelope, and it didn't always turn out well because I didn't do things that would improve the chances of it healing. So in simple fracture patterns, think about fracture reduction takes stress off your implant, and it takes the fatigue problem off your implant. So let's see, the other thing to remember is, like with nails, you know, the pi r to the fourth, you don't have to remember the whole equation. Just remember, if I change the radius by even 0.5, that significantly increases the amount of axial stiffness that, or rigidity, that you provide. And then plates are half times the base height. So those are simple formulas where you don't have to memorize all of the equations. You just have to memorize, like, what am I going to do? Like, what are the variables that I change? And so I really think about, like, I'm a believer of parent strain theory. And so I really think about that in the simple fracture patterns. Like, if I, for whatever reason, have to bridge it, then it's going to be a very long, flexible implant. And I try to use compression techniques whenever I can. I think that femur non-union that I showed, like, that's another one that I was like, this has had so many operations. I need to really just compress it a lot. And so compressing it on both sides, but trying to be biologically friendly while you do it, because the thing that biomechanics doesn't really account for is the biological part. And so, like, biomechanically, you'd think, well, if I get the fracture surfaces to touch, that helps. If I compress the fracture, that helps. And then if I make a construct super stiff with the fracture, you know, doing the absolute stability, then that helps. But if you know, that's the kind of the error that some of the AO techniques had early on, is that people would say, oh yeah, I need to directly reduce it, compress it, and do rigid implants. And then they stripped everything around. So that's where you have to also think about the biological part. So you can't kill the bone in your effort to make a biomechanically rigid construct.
Okay, doctor, thank you. We have a question of Natalia Correal. Natalia is a PGI1. So please, Natalia.
My question was, what are the main challenges in biomechanics right now, and towards where is the new technology and investigation heading towards?
I think you know, from a fracture standpoint, I think it's around smart plate technology and making the screws are changing a little bit. There's some companies that have different, they're called fasteners, but different screw patterns, like how the screw is designed to help improve the amount of pull-out resistance. So it's going to take more force to pull the screw out. There are companies that are designing plates that allow for some motion. So it's kind of got generated from distal femur fracture non-unions, because that's an area where we went crazy with making stiff constructs, and then they had a high non-union rate. And so, like, Zimmer has designed the far-locking construct, where basically it allows for motion in the screw around the screw shaft because of how the screw design is. But they're actually designing plates that allow, I don't think they're I don't think they're available everywhere now, but basically it allows for, with axial loading or with movement, it allows for some micro motion of the plate, so it decreases the stiffness and improves fracture healing. There's also, I mean, for about 15 years, they've been trying to develop smart plates where you get feedback with by having strain gauges on the implant and trying to get that data in a meaningful way to the surgeon to say, oh, I think it's okay to let this person weight bear on their plate now. It's fine because they've got some or they have decreased strain because their bone's starting to heal. So I think those are the things that are developing. I mean, there's always companies that are trying to develop new nail designs or things like that, or locking bolt designs to improve fixation with either to avoid too much motion with like medullary nails as well, or better fitting nails to improve cortical contact and avoid problems with, like in geriatric patients, if you have a large radius of curvature, you could potentially put the nail out the front of the distal femur. So newer nail designs have a smaller radius of curvature to match the more bowed femurs as we get older.
Okay, thank you. We have another question of another PGI1, Juan Sebastian, please.
Thank you, Dr. Crist, for that excellent lecture. I wanted to ask you, so actually it's two questions. For the first one is, do you actually use the working length in intramedullary nails in diaphyseal fractures to guide your rehab process on your patients? And if you do, how do you use it? And the second question is, I know that you authored the arthrodesis chapter in the book, and I just had a doubt in how do you use the stress theory in order to prevent arthrodesis failures, for example, in the knee.
Thank you for bringing up the nail working length, because that's something that I thought of as I was going through that I wish I would have kind of hit on, because there are some diagrams that make that easier to understand. So I do think about, not so much in my post-operative rehab protocol, because I think, I let probably 95% of whatever nail I do weight bear. I think, you know, unless they just have really poor bone quality, that may be a reason. But, you know, one of the benefits of the nail is that it is along the anatomical axis. And so the you know, the stress that the implant sees is important. You know, you can break locking bolts, but that's where I would think about more of the working length, as far as, you know, how good of a fit in the diaphysis do you get with the nail, how comminuted the fracture is. So if you have a simple fracture and you have great diaphyseal fit, your working length is really kind of where you have that point of contact. If it's if the nail's not getting good contact in the endosteal surface, then it's really to that screw. And so if you have a comminuted, like that retrograde nail that I showed with a comminuted subtroche, like that working length is very short. And so that guy, I don't remember specifically, but he may have been somebody that I limited their weight bearing. And so I do think about it. I think, you know, there's some, a paper that was published in JOT, and then there was a presentation at the OTA this year about using 10 millimeter nails in femurs. And like, do you need to have, that was one of the, I don't know if you guys have access to the podcast for the OTA, but that was one of the game-changing articles that Mike McKee talked about. Like, he thought that was great. And I think it is great. You know, I don't push the biggest nail possible. But I think if you do 10 millimeter nails in everybody, I think you are going to have some failures, and that's fine. And they showed Dr. Muir and Tampa group showed that the failure rate was still very low. I mean, I think they still had like 95% healing. And so then maybe you only have 10 millimeter nails, but then I'm going to increase the number of locking bolts. So for femurs, regardless of the nail size, I'm going to do 2 locking bolts above and below. But if there's not really good diaphyseal fit, or, you know, they have a large canal and I can't fill it for whatever reason, then I'm going to probably put 3 locking bolts distally and proximally. So I think about the working length and the amount of time it's going to take to heal, and the fatigue that it causes on the locking bolts themselves. I think for the arthrodesis, that's a great question. And so the way that, so I'll maybe ask you kind of a follow-up, but the way I think you can get arthrodeses to work with medullary nails is through compression. And if you were talking about maybe can you kind of be more specific about like the knee part? Are you talking about with the tantalum augments, or what particularly were you doubting?
So actually, I was doubting how do you actually compress, because it is my understanding that in general the nails are more like a relative stability type of design and construct, and then it is hard for me to understand how do you actually get a good compression and try to stimulate or try to have a primary bone healing when you're doing an arthrodesis. I just don't understand exactly how that happens. And I was thinking about.
Yeah, that's a great thought. So most of the nail designs, like for hindfoot fusion nails, some of the knee fusion systems, like they have instruments that go along with the nail insertion jigs that create compression. So like the hindfoot fusion ones, which were some of the cases that we had. Basically, you get your tibio talar joint, like the nails across it, you put screws proximally on the nail, and then there's a dynamic slot that you put your screw in, and then you use an external compression or an internal compression device to basically move the nail along that slotted screw. So number one, you put the surface together so you're not kind of keeping it distracted when you put your screw in. And then you can use things that attach to the nail insertion so there's a screw that goes inside the nail, or different nails use different devices, but basically it's like a screw that goes in and works against the screw that you put in to pull the nail, essentially, so you're compressing the surface that you're trying to get to heal. And then you can do the same thing with the subtalar joint by putting another screw or using an external device with the nail system to compress the joint before you fix it. So I think you're kind of getting some secondary bone healing with nails for fusions rather than like a plate arthrodesis or a screw arthrodesis for an ankle joint, where you have compression screws across the joint or a compression plate across the joint. And then I think we had where we had the metal augments basically to make up for bone that's lost. And so that basically acts like a compressible bone surface because their modulus of elasticity is closer to bone.
Doctor, thank you. We have another question. I only can see the raised hand, but I don't see the name. So please, you can talk in this moment. No, I think it's...
Thank you, Dr. Lea.
Okay.
This is me, Luis Useche. Thank you for a great conference. I would like to ask you about biomaterials. What's your opinion about titanium and stainless steel plates for femur and tibia? We first had almost all the plates in stainless steel, and then after that we jumped to titanium, and then again we jumped for stainless steel. I mean, I would like to ask about your opinion about this two material for femoral tibial plate.
Yeah, so that's a great question, and you're right. So there have been some studies. We did a distal femur. Most of them are retrospective, but we did a distal femur plate study where it didn't matter what metal we used, if they were stainless. It led to non-union was if you used all locking screws in the diaphysis. And then there's been a study out of Harvard. And then there's been another study out of Canada that would say titanium is important, and you should use titanium. And so I've actually gotten to the point where I prefer titanium because I like that the modulus of elasticity is closer to bone. I think it's also more resistant to infection. And I think the problem with stainless steel is that you're more likely to make a rigid construct. So the downside to titanium, especially with locking plate technology, is where the screws with the load that it sees, and companies can say that it doesn't happen, but it's called cold fusion, or basically where the cold welded, where the screw head gets stuck to the locking mechanism in the plate. And then when you go to take it out, you have to like drill like crazy, create a bunch of metal debris to get the plate off. And so that's the downside of titanium. It can happen in stainless implants, but few and far between in my experience, just because the stainless is a much harder surface. So there are plates for their, I think, Biomet still has their, and some other companies have, where they have the screws of dissimilar metal. So they're cobalt chromium screws to where that cuts into the plate. I haven't had to take those screws out into a titanium plate because it's a harder metal screw. So that may not be as big of a deal, but basically with axial loading, mostly you're going to get some displacement of the fracture in the plate with the loading. And so those screws get kind of stuck and basically fused to the plate. But I've gotten to the point where I prefer titanium if I can get it. It's hard to get, it's more expensive, but there are companies that's what their line of implants are. So.
Thank you, Dr. Chris. It's almost 7 o'clock, so one last question. Dr. Gomez, please.
Good night, Chris. Thank you so much for joining us in this new journey in our career in trying to understand the biomechanics and the use in our daily life in orthopedic surgery. I have a question about the increasing use of the variable angle locking screw, because there is so much controversy about their use. Some people are saying that it's increasing the possibility of failure of the construction in the distal femur fracture, for example. What do you think about that?
Yeah, so the biomechanical testing would say that it's about 85% the stiffness of a regular like monoaxial screw. Companies have different ways of trying to make a variable or polyaxial design. So the paper that you're talking about is the Houston paper. They had like a 20-some% failure rate, but the Mississippi paper showed that their failure rate. And so I think for distal femur fractures, I think we kind of get stuck in the mindset of only putting a lateral plate on. So that's part of the point of me talking about medial plating a little bit, is that you put the plate where the buttress side is. That's what I like to do. And then if you have a very comminuted fracture, instead of, I used to do medullary plates or cortical substitution plates, we put it inside. I now put dual plates, so you can do it in a biologically friendly way, comfortable with the subvastus approach. I don't think that they have data from HSS, an MRI cadaver injection study that showed that a medial plating in a biologically friendly way only decreases the blood supply. By adding a medial plate, only decreases the blood supply by about 20%. And so I think that's where we need to focus, because if you have a super comminuted distal femur fracture from bone loss, for open fractures that are going to take a long time to heal, or complex fractures, I think we're asking too much for just a laterally based plate to make it.
Okay, thank you. Dr. Chris, one more time. We are very happy that you have accepted our invitation. It was an excellent lecture. So thank you very much. And we hope we can count with you more another time in the future. So thank you very much. And I don't know if you want to say something.
I was going to say it's a pleasure. It's great to see friends. I'm glad that we, in this kind of challenging time, that we can still remotely get together and learn from each other. So I really appreciate the opportunity, and hope you guys have a great evening and a great weekend.
Same to you, Dr. Chris, and thank you very much.
All right. We'll see you later, guys.
See you later.